Welcome back to Biology 141. This is going to be our unit on joints today. So first thing we need to ask, what exactly is a joint? A joint is actually going to be a point of contact. It could be a point of contact between two or more bones. It could be a point of contact between cartilage and bone. And it could be a point of contact between teeth and bone. Joints are going to be classified based on their function and their structure. So we talked about the different definitions of those types of joints. So they can be classified in two ways. It could be classified by the type of tissue that's going to bind the bones together. For example, you could have a fibrous tissue that's binding them, so it could be a fibrous joint. You could have cartilage that is binding them together, so it could be a cartilaginous joint, or it could create a capsule where you might have some fluid in between that joins those two bones together, and that would be a synovial joint. By the type of movement is also going to be another way that you can classify these types of joints. And so it could be something that we refer to as a synarthrotic. It could be an amphiarthrotic, or it could be a diarthrotic. So we're going to use both of these things in order to classify these types of joints. So it's function and structure. So looking at a little bit closer, when we talk about a synarthrosis or a synarthrotic joint, this is going to be an immovable joint. This would be an example of a joint that's found between bones that come together in the skull. So these could be sutures. They're going to fasten together with connective tissue, or it can fasten together using something such as a hyaline cartilage. Now with this type of joint, the synarthrosis, it's going to actually have four types that fall into this category. It could be called a suture, like what you see here with the skull. It could be called gumphosis. It could be synchondrosis or synaptosis. So looking at each one of these, the synarthrosis, of course, again, like we just described, means no movement. And so here, these bony edges are going to be quite close together that you see that are going to be in the skull. And these are going to be extremely strong joints. They're going to be located where movement between bones must be prevented. You do not want the bones in your skull to move because that could damage your brain. And so in this case, there are going to be several different ones we look at. So with the ones in the skull, it's going to be the sutures. And so that's going to bind these bones together once that skull has fully formed and come together. The next type we have, of course, is the gumphosis. This is going to be, for example, what holds the teeth in tight. And so it's going to bind these teeth into those bony sockets in the maxilla and in the mandible. And that's going to use a fibrous connection between the tooth and the socket. And that's going to be referred to as periodontal. And so peri means around, and odontus is going to be tooth. So this is going to use the periodontal ligament to actually hold these teeth in, and that's your gumphosis. The synchondrosis is going to be what you would see right here, where you have the costals or the ribs that are coming in to the sternum. So the top one, you see it there coming in to the manubrium part of the sternum. And then you see that second rib underneath there that's coming in on this picture, the second rib, that's coming into the portion that's binding at the body part of the sternum there. And so with this one, it's going to be a rigid cartilaginous bridge that is actually going to be formed between two articulating bones. And so you see that there in the picture. Just a minute and I'll get my marker here. So this is what you're going to see here. And it's going to be in that silvery blue color. And so it's going to be that cartilaginous connection between both of those ends, and it's going to come in and connect there to that manubrium, like we said, and to the sternum. Another example is going to be the epiphyseal cartilage, which is going to connect the diaphysis to the epiphysis in the growing long bone. And so when you went over bone tissue in the previous chapters, you did learn about that section of bone, and that's going to be where that bone extends itself and grows stronger. Now coming down to the synostosis, this one's going to be the type that you see here, where it's going to be a totally rigid, immovable joint that's created when two bones fuse together and a boundary between them disappears. And so you can see that there on that frontal bone in the skull. Let me Circle that right there. You can see where that comes in together. So eventually, for the most part, it fuses together and you can't see where it was more than one bone on there. This rare frontal suture of this frontal bone that you see here is going to be where at first, when it was two separate bones as an infant, it came together and it fused. Get rid of that. All right, so the second type, the amphiarthrosis. These joints are going to be slightly movable. An example of this would be the joint that you find in the pubic symphysis. It's going to be right here through the center section, and that's going to be slightly movable for women during pregnancy. It's going to be there to allow for those hips to kind of loosen up and to spread slightly in order to allow the head and the body of the baby to go deeper into that pelvis to prepare for birth. Now with this, there are also going to be other examples. You can have intervertebral discs where you can find these types of joints, so they're going to be slightly movable, but you do not want them to move a lot. And in this category, it has two of its own types. And so you have syndesmosis and you have symphysis. What we're seeing here in this picture, of course, is the symphysis example. So with that amphiarthrosis, like we said, that permits more movement than what we just saw, but it's still going to be stronger than those freely movable joints. So the articulating bones are going to be connected by collagen fibers or by cartilage. So the top one that you see here is going to be the syndesmosis. This is going to be where bones are going to be connected by a ligament. So you can see how those bones there are connected to each other. You do not want them to move apart from each other. An example would be a distal joint in the tibia and fibula, or you could have an example of the distal joint that you would find between the radius and the ulna. Then below that is the one that we just looked at. That is the symphysis, and that's going to be found that connects the two coxa together, each side of the hip. And so that's going to come together right there, and it is going to be like a wedge or a pad of fiber cartilage. And so that joint between the two pubic bones is that pubic symphysis. The third type, you have your diarthrosis. This one's going to be a freely movable joint. Also, it's known as a synovial joint. So you would find this in the elbow or in the knee. They're typically going to be located at the ends of long bones, such as bones of the upper and the lower limbs. And so, of course, the types, you have your synovial joint, like we just said. So looking here, it kind of creates that ball and socket type that you find up top. You will see that in this area, you will have an opening, which will have a synovial cavity in it. That cavity will have a synovial fluid. Now, with these types of joints, they do tend to sometimes inflame. And so you might need to, you can see where you go to the doctor sometimes and you have to draw this fluid off if it inflames or it swells too much. With the diarthrosis, this is going to be, like we said, a freely moving joint. And so it can be moving on several different planes. So the planes of movement you can call monoaxial. And this is going to be movement in one plane. That's going to be the elbow and the ankle. So it goes in one way. Biaxial movement, it's going to move in two planes. So that would be things such as the ribs and the wrist. If it's a triaxial movement, that movement can move on three planes. That would be such as the shoulder and the hip. That's where you would need the most rotation and the most movement. And so with these synovial joints, like we said, that your freely moving joints permits a very wide range of motion, more motion than the other types of joints will allow. And like we said, typically located at the ends of long bones. So structural classification of joints, we talked about that fibrous joint. That has a lack of a synovial cavity, so it won't have that cavity that's open with that synovial fluid. Articulating bones are going to be held together with a dense, irregular connective tissue. And so with that dense, regular connective tissue, that means that fibers are not going in the same direction. These fibers will be going in all different directions. And it also will prevent little or no movement. And so again, this would fall under the sutures or your immovable joints. Here's an example of more fibrous joints. And so you see them falling in between the bones of the fibula and tibia, and you see it in with a periodontal ligament. Cartilaginous joints are going to lack a synovial cavity, and the articulating bones are going to be held together with a hyaline cartilage or a fibrocartilage. These will permit little to no movement. So these can be found in things such as in the growth plates. So you see here it's an epiphyseal plate. Now remember, once these plates ossify, that person has finished growing and that bone cannot grow anymore. But as long as it's still a growth plate or an epiphyseal plate, it is cartilage. And so here you would see that type of joint. Another one, you have your pubic symphysis there. Now to the synovial joints. These, of course, have that synovial cavity, which is going to be the opening that will contain a synovial fluid. The articulating bones are going to be covered with articular cartilage. That's going to reduce any type of friction between these bones, along with that padding from that synovial cavity. They're going to be held together by ligaments. They contain that synovial fluid in the cavity and have a nerve and blood supply that go to it. They're going to be surrounded by an articular capsule as well. These are going to be the ones that permit the largest range of movement and motion. And so here you see it a little bit closer. You have the two articulating bones. You're going to have your articular cartilage, which is going to be found in the light blue, which is going to be at the end of each bone. You'll see that you have this capsule that goes around and connects it in. The joint cavity is going to be the openings that you see through here, which will contain a synovial fluid. And then you'll have a synovial membrane that kind of outlines this cavity that you'll see in this light pink on the edge here. And then, of course, a fibrous joint capsule, which is going to be in that gray. Once I remove all this drawing, you'll be able to see it. And that's going to help to hold these together. So I'll remove that so you're able to see. Now the bursa and tendon sheets. Bursa and tendon sheets can be found at many synovial joints. Bursa are going to be sac-like structures that are going to be filled with synovial fluid that cushion movement of one body part over another one. These can become inflamed also and can swell, and then you would end up with a condition called bursitis. Tendon sheaths are going to be kind of like tube-like bursae or bursa. They're going to wrap around tendons that are subject to a great deal of friction. So looking here, this is going to be in the leg. You see the patella, which is your kneecap in the front. Of course, you see the femur, which is the thigh bone. You see the tibia, which is the shin bone. And inside, you're going to see that you do have some fat pads there. You have meniscus there. But you also will see that you have the synovial membrane and you have a suprapatellar bursa. And so that's going to be a protective padding that's going to be found there. Also underneath, you have an infrapatellar bursa, and that's going to help to cushion and kind of work as a shock absorption. Now, in with this knee joint, the largest and most complex synovial joint is going to include what's called a chondroloid joint. And that's going to be between the medial and lateral condyles of the femur and the medial and lateral condyles of the tibia. And it's going to help to create a gliding joint with this between the femur and the patella. It's often referred to as a modified hinge joint because of this. So as you look in, you can see that you have a cruciate ligament, the anterior, which is coming around that front area there, which is connecting that femur into the tibia. You can see you have a posterior cruciate ligament, which is coming in from behind, that's also connecting it in. You can see you have your lateral meniscus coming in. You have a medial meniscus coming in. And then you see your other ligaments that are connecting, like the fibula to that tibia there. Also, you have the fibular collateral ligament, which is going to connect in here from that femur coming down to the fibula. And you'll have one that's going to be on the opposite side called the tibial collateral ligament, which is coming from the other condyle of this fibula and is of the femur, and it's coming down to the tibia here. All of those work together to help hold the knee structure stable and to help allow movement. Looking here, you can see that the different types of movements because of these ligaments are going to allow things such as flexion and extension. Flexion, think of bringing two bones closer together. Think of flexing your muscle. If you were doing it in your arm, you would be bringing the forearm closer to the upper arm. And so that would be your flexion. Extension would be extending or stretching out. So think of taking those two, the lower forearm and the upper arm, and extend it out to make a lot of distance between the two. The movement it also allows with this type of joint that you see here is going to be a slight rotation, and it allows that locking of the knee. Joint capsules are going to be relatively thin, and they're going to be strengthened by ligaments and tendons that you'll find around them. Ligaments here are going to be both anterior and posterior that we looked at, those cruciate ligaments, and they attach the bone inside of the joint capsule. So we saw how they come across and they kind of crisscross almost in an X motion, and that's going to help to reinforce that stabilizing of those bones. This will prevent the femur from sliding off of the tibia. Also, we looked at the menisci, or meniscus in the other picture. This is actually taking the femur off and looking down. And so you're looking down onto that tibia, and they allow those menisci to stay there. So you see that, get my pencil. You're going to have this lateral meniscus that's going to be on the outer portion of the leg. You have the medial meniscus that's going to be on the middle portion, so between the two legs. Medial will be on the inner portion. And so those help to separate the articulating surfaces of the femur and the tibia. They also help to compensate for the differences in their shape. So they're padding, but they also help to fit these two bones together well. Now looking at it closer, you can see the different ligaments that are attaching here. So one that we have not looked at yet is this transverse ligament, which you see connecting the lateral and medial meniscus here. You see the posterior a little bit better from the back view. So this is coming from the back of the leg, and it's going to come in and connect around. You see that you have your anterior, it comes and connects around towards the back portion. And this is what it actually looks like on a cadaver. So you can see what that tissue actually looks like in a human. And here's another one where you can compare these differences of the knee capsule and that tissue. Now with the shoulder joint, it's a ball and socket joint. It's going to consist of the head of the humerus and the glenoid cavity of the scapula. Let's go into this. So here's your head of your humerus, and here's that glenoid cavity that they're talking about with the scapula. So here's your scapula here. And so with that, it's going to enclose this by a loose joint capsule. And so we see this, it's going to go around and enclose that humerus there. It's going to allow for a lot of freedom of motion, and it's not going to be as stable. Now with this, you need that motion in order to move your arms around and to do a lot of things with them. So that glenoid cavity, like we said, is going to be the socket area, and it's going to be relatively shallow, so it's not going to be a deep socket. It's going to be lined with the glenoid labrum. That's going to be made up of a fibrocartilage, and that's going to help create a tighter fit there. And so that labrum, you're going to see through here, and it's going to go up. And so that's what helps to create that fit. Of course, you have the cavity through here. Inside that cavity, you're going to have the synovial fluid that's going to fill that up. And then, of course, you have your articular cartilage, which you'll see in that silvery blue that's actually going around that humerus bone. Here we are looking at it from an artist rendition or a drawing of another picture. They actually have the arm lifted up, so you can see that joint cavity. It's filled with that synovial fluid. It's going to have a membrane that goes around it. It has a bursa up top, which is going to help to pad it from the top portion. And you can see the articular cartilage at the end of each set of the humerus and at the area that's going to go around the glenoid section right through right through here of the acromion section, or that glenoid section of the scapula. Now with the shoulder joint, it's going to be reinforced by surrounding muscles and tendons. This is referred to as your rotator cuff. So lots of times people, especially that play like baseball and softball, you hear about them messing up their rotator cuff. This is the area that they're referring to. So several ligaments are going to help to prevent displacement of bones in this area. You have that coracohumeral ligament. You're going to have the glenohumeral ligament and the transverse humeral ligament. And so going in here, this ligament that you're going to see, sorry, my pen did not come up. All right, so right here, that's going to be that ligament there, and that's going to be the coracohumeral. That's going to come in and attach into that humerus to help stabilize it. Then you have the glenohumeral ligament, which you're going to find in here. That's coming from that glenoid cavity. And then the transverse humeral ligament, which is going to be, which comes across in these transverse fibers that you see here. That's going to attach it in. And then, of course, you're going to have several bursa. And so this is just a closer picture for you to look in. So with the bursa, we're going to have, I'm trying to jump ahead with the pen and it's not wanting to work. I apologize for that. All right, I think it's ready now. So here is a bursa pad that you're going to see. That's going to be your subacromial bursa. It's going to come in with this acromion process that's up here in the scapula. Underneath, you're going to have this area through here, and that's going to be called the subscapular bursa. And so that's going to be in the anterior portion of the scapula that's actually facing into the body. And so that one's also going to be a pad there. This is going to be what we just looked at, but this is actually what it looks like inside of a cadaver. So this is what it would look like inside of you. Moving on to the hip joint. This is going to be another ball and socket joint. It's going to be found between the head of the femur and the acetabulum of the coxal bone. The acetabular labrum is going to line the cavity for better articulation. Unlike with the shoulder, these articulation surfaces are going to be held together by a heavy joint capsule. It's going to be well reinforced by several different ligaments. So we're going to have our iliofemoral ligament, our pubofemoral ligament, and our ischiofemoral ligaments. And so here these bones are going to be held closely together. They have joint capsules. They're going to be tight, and they're going to have a lot of ligaments that are going to be really strong here. So looking in, we have the coxa, which is going to be one half of the pelvic girdle. With that coxa, remember, it consists of the ilium, the ischium, and the pubis. Coming in, you have that joint cavity. You have the articular cartilage, which will be found on both bones. It'll be found in that acetabulum of the coxa, and it will be found on the head of the femur there. When that, you have a synovial membrane that's going to line over top, and then of course you have that joint cavity which has that synovial fluid inside there for the padding. Here you see a ligament that's coming up and attaching into the head of the femur, and that's going to attach into that fovea capitis, if you remember that, found on the head of the femur there. And that ligament is referred to as the ligamentum capitis there. You also have that joint capsule which is forming around the bottom area, and notice that you have a joint capsule that's forming around the top portion too. Now coming in with the ligaments that we talked about, with that iliofemoral ligament, that's going to be this ligament that comes in through here. So that's all of this. You have that ischiofemoral ligament, which is going to attach actually here at that ischium. And so it's going to come in and attach here to the greater trochanter of the femur. Now with the iliofemoral ligament, that's coming in from that iliac portion of the coxa. Now with the elbow joint, this is going to be a hinge joint. It's going to be found between the trochlea of the humerus and the trochlear notch of the ulna. It can also be a gliding joint when it's found between the capitulum of the humerus and the head of the radius. It's going to contain a joint capsule which is reinforced by the ulnar collateral ligament and the radial collateral ligament. The annular ligament is going to form a ring that goes around the head of the radius, and it's going to help to hold it in place. Movement for these is going to be flexion and extension. So here you see the humerus, which is going to be the top bone coming in. You see that it does create a joint capsule, which you will find around the anterior and posterior parts. You see inside of it that it has a joint cavity, which will have that synovial fluid. That's what you see there in light blue inside of the joint. You see the synovial membrane going around it in this navy. And of course, it's going to be on both sides there. The articular cartilage is going to be the cartilage that you find going around each bone. And in this picture, it looks like it's white. And so that's your articular cartilage that you find there. This is going to be a view of those ligaments that you have in the elbow. And so with this, you see this annular ligament that's coming around that radius there. You see you have an articular capsule that's being created through here. You have the ulnar collateral ligament, which is forming here and here. And coming further down, you have where you can see this annular ligament coming and attaching that radius to the ulna here. You see the radial collateral ligament, which is coming in from that humerus and attaching in to the radius here. And also notice how with this ligament, it can come in and attach here to that ulna. Now with different types of movement, you can look at the picture and it describes this. So if you're talking about extension, you're moving something away. And so in this case, moving the head straight up keeps it the furthest away from the trunk or the chest. If you want to flex it, you would move it towards your chest. If you want a hyperextension, you're going past straight up and down, and you're actually looking up at the sky, and your neck's going back, or your head's going back. You can also do it with your arms. So you see with the flexion, the arm comes up. Extension, the arm starts to go down, and hyperextension, it goes back. You can do the same thing with the legs. Now with the intervertebral joints, you can do what's called lateral flexion, and that's where you will bend from side to side. Another type of movement is referred to as abduction and adduction. This would use the shoulder joint. So think of doing jumping jacks. So if your arms are going up, they are abduction. If they're coming back towards the body, they're referred to as adduction. Looking at the hand with the wrist joint. If you move the hand away from the body, that's going to be abduction. If you move it back towards the body, that's adduction. With the leg, moving it away from the body, abduction. Moving it back, adduction. And then you could do it with the fingers as well. Fingers away, spread apart, abduction. Fingers together, adduction. It's hard to, you gotta really listen for the ab and the ad. Now circumduction, that's gonna be able to move things in a circular motion. And so here you see that you can move your arm in a circumduction motion, and you can move legs in circumduction motions. So that could use your shoulder joint and your hip joint. Gliding motions can be made with the carpals here. So we can see gliding between the carpals with those arrows. So it can go up and down and side to side. Okay. Rotation. You have an example with the head where you can look from side to side, or you could have a lateral rotation with the arm where it goes out to the side. You can have medial rotation where it comes towards the trunk of the body. Same thing with the legs. Lateral rotation goes out to the side. Medial rotation comes in towards the median of the body, and that would be with the hip joint. Temporomandibular joints will be the joints of the mandible attached to the temporal bone, and elevation versus depression. So elevation, you're bringing the chin up, teeth together. Depression, you're bringing the chin down, which would pull the teeth apart. Now looking at that chin, you could do a protraction or a retraction. Protraction would be sticking your chin out or jutting your chin out as much as possible. Retraction would be bringing it in as much as possible. Those also would use the temporomandibular joints. Okay, the intertarsal joints. You can have inversion, where you bring your foot in towards the midline of your body, or eversion, where you try to bring it out, away from the body. You can point the foot up towards your shin using the ankle joint, and that would be called dorsiflexion. Plantar flexion would be in a regular standing position, just pointing out. And then coming down, you would be doing a plantar flexion. And so you can go up for dorsi, have a resting, and come down for plantar. That's like pushing the toe against the ground, or think of like ballerinas, pointing that toe hard. Radioulnar joints can be used in what's called supination and pronation. Palm, which is facing up, is referred to as supination. Palm, which is facing down, is going to be referred to as pronation. And then you can use your carpometacarpal joints, got tongue-tied there, and that's where you use opposition, and you can reach and use your thumb to touch your little finger, your ring finger, your middle finger, and your pointer finger. So all of those would be opposition. Aging in joints. So as you age, your joints are going to start to age and deteriorate as well. You're going to have a decreased production of synovial fluid. So with less fluid, there's going to be less shock absorption. There's going to be less protection there. You're going to have thinning of the articular cartilage. That's going to be the cartilage that's found at the ends of the bones. And so it's going to be less protection for those bones as they come together. You're going to have loss of ligament strength, length, and flexibility. And so this is going to cause you to not be able to move as fluidly or freely, and it might make you more stiff. Arthroplasty is going to be common in older people or common in people as they age. This is where they go in and do a joint replacement surgery, and that can be performed to counter some of the effects of aging. So if you have bad knees, they can go in and do a knee replacement. If you have bad hips, they can go in and do a hip replacement. So with that, the arthroplasty is going to be a major surgery that they perform quite often. That's a surgical procedure that repairs and replaces some or all of the joint, depending on what type of surgery that you need for this. They can go in, they can resurface that bone. They can actually go in and take parts of the bone out and put in an artificial joint in. But most commonly, they replace the joints in the hips and the knee. Those are the ones that you will see the most for arthroplasty. So here's one where they go in and they are actually going to go and cut the head of the femur out, and they're going to reshape that acetabulum when they do that. They can go in and put a metal, ceramic, or even a plastic replacement on the top of the femur and do that hip replacement with these types of materials. Going in, this one's going to be a knee replacement. And so you can have the femoral component where they shave the portion of the femur down with the condyles, and they can go in and replace it with those same materials. You can see you can have a plastic spacer put in at that tibia, and you can have a patellar component where they go in and even replace a patella or a kneecap there with an artificial kneecap. With joints and age comes different joint disorders, and even sometimes without the age, some people are born with different types of joint disorders. With these, the articulating bones are going to be moved out of their proper alignment, and it could be caused from injury due to unusual body movements. So symptoms of this could be things such as localized pain, decreased movement, swelling, and of course, deformity over time. Most common dislocations with the joint disorders is going to be a shoulder dislocation, followed by knee dislocations, elbows, fingers, and even your jaw. Sprains are going to be caused by the overstretching or tearing of soft tissue, ligaments, or tendons around a joint. Symptoms for this could be pain, swelling, and restrictive movement. And sometimes they say that sprains actually could hurt as bad or maybe even more than the broken bone. So lots of times people think that they have actually broken a bone when it's really a sprain. Bursitis, this is going to be the inflammation of the bursa. This is going to be caused by overuse of the joint or stress on that bursa. Example of this would be things like tennis elbow. Treatment is, of course, always rest and elevation and taking anti-inflammatory drugs. Things such as ibuprofen, Advil, those types, NSAIDs. Next, we have arthritis. Arthritis is a very common condition. There's different types. You could be born with a genetic condition such as rheumatoid arthritis. You might develop different types of arthritis as you get older due to use of your joints. But basically, arthritis is going to be inflammation of the joints. It's going to produce inflamed, painful, and often swollen joints. And of course, there are more than 100 different types. There's many different types of arthritis here. Like we said, rheumatoid arthritis, that is a genetic condition. That's where it goes into the joints, and lots of times it will cause a change in those joints, so where the fingers or the toes can actually look like they're misshapen. You could have osteoarthritis. This is going to be arthritis that's usually found later on in people as they age, and it causes a lot of pain. So we're going to go into each one of these. So with the rheumatoid arthritis, this one is going to be an autoimmune disease. Like we said, this is usually going to be genetic. The body's going to launch an immunological attack against its own healthy tissue. This one they do say is the most painful and debilitating of arthritis. This one often can occur in people as young as their 20s or 30s. What's happening that actually causes this? Well, the synovial membrane is going to become inflamed. After inflammation for so long, it begins to thicken. It will damage the articular cartilage that's found at the end of each articulating bone. And then once you have this damage and constant inflammation and the thickening, you're going to have a fibrous tissue starting to come in and invade. So these fibroblasts are creating fibro tissue, which doesn't do its job, and it's going to invade into these areas, and it's going to cause these joints to ossify and the bones to even fuse together. Usually this is going to be what we refer to as a systemic illness. So you could end up, along with this, fatigue, muscular atrophy. That's where the muscles start to break down and aren't used as much. You could have anemia and osteoporosis. Changes can be found in things like the skin, the eyes, lungs, blood vessels, and even in the heart. With the osteoarthritis, this is going to be a degenerative disease. It's the most common type of arthritis. Usually it's going to be found in older people or people as they age. It's found at the articular cartilage of bones. So remember, that's going to be the ends of the bones that articulate with each other. It actually starts to soften and disintegrate gradually. So it breaks down and becomes where the ends of the bones actually start to grind against each other. And so it's going to make them rough, and it's going to hurt really bad with that. And so with this, the pain tends to worsen as the day goes on, and activity makes the pain even worse. You end up with a lot of stiffness. It's worse usually when you get up in the morning or if you've stayed still for a long period of time. And with this type, there tends to be a lot of swelling as the day goes on, and activity will cause more swelling and pain. Another type of joint disorder would be gout. This is also an inherited illness involving a defective missing enzyme that allows uric acid crystals to accumulate, especially in the knees or in the foot. So this one is actually most common between the big toe of the foot, though it can be found in other joints of the toes. Mainly it's the big toe, which is going to be that first metatarsophalangeal joint there. And so it can be a form of acute arthritis. So it's very painful. Another type of arthritis is one that you can catch from a tick bite. This one is Lyme's disease. Lyme's disease arthritis is caused actually by a bacterial infection. So the bacteria in the saliva of the tick that bit you actually causes these symptoms in your body. So usually first thing that you'll see is going to be a rash that looks like a bullseye, followed by fatigue, flu-like symptoms, and aches and pains. You'll have intermittent arthritis that affects several joints, and this type usually starts to develop weeks after the initial symptoms, so you usually don't have them at first. That's going to end us for our unit on joints. I'll meet you back here for our next unit.